Hi there, this is Dr. Hamadi. I am coming to you with the lecture on postpartum complications. This is all covered in chapter 28 of your textbook for you to review as well. The objectives of this lecture are to describe the predisposing factors and causes, as well as signs and therapeutic management of postpartum hemorrhage, subinvolution, superficial venous thrombosis, deep vein thrombosis, pulmonary embolism, and postpartum infections. We're also going to be discussing postpartum depression and postpartum psychosis. And of course, we'll be discussing the role of the nurse in the management of women with postpartum complications. Postpartum hemorrhage is one of the most frequently occurring complications during childbirth. It occurs in the first 24 hours. It usually occurs in the first 24 hours of birth, but it may occur up to 12 weeks after delivery. And this is the leading cause of maternal mortality and morbidity. So I can't stress enough the importance of understanding this potential complication. You'll remember that normal blood loss following a vaginal birth is quantified as less than 500 milliliters and less than 1,000 milliliters for a cesarean birth. Blood loss is often underestimated whenever we're visually making an estimation, usually by about half. So it's really important that we're actually weighing and measuring to more accurately assess for the patient's blood loss. Risk factors and signs and symptoms and management can be differentiated between early and late postpartum hemorrhage. So we're going to start by defining those parameters. Early postpartum hemorrhage is it usually occurs within the first hour. That's the most critical time, but early postpartum hemorrhage is really defined as any hemorrhage that occurs within the first 24 hours. Uterine atony, which is the decreased muscle tone of the uterus, is the most common cause for an early postpartum hemorrhage. Trauma may be caused by lacerations, and that can occur anywhere along the birth canal. Hematoma can cause concealed blood loss. Retained placenta and membranes is something, anything that's retained inside the uterus can prevent uterine contraction. And also placenta accreta or uterine inversion can also result in hemorrhage. A late postpartum hemorrhage occurs after 24 hours and up to 12 weeks postpartum. Of course, it's always most risky whenever the most high acuity time is going to be closer to the birth, but it can occur up to 12 weeks postpartum. The most common cause for a late postpartum hemorrhage is something called subinvolution. You'll remember that involution is that normal progression of the changes in the body to take the patient back to a non-pregnant state. Subinvolution is the slower than expected return to that non-pregnant state. The most common cause for subinvolution is going to be, something that's retained within the uterus, like the placenta or some membranes, and that can lead to infection, or infection can occur on its own and cause some subinvolution. Understanding the risk factors is really going to help the nurse to anticipate a postpartum hemorrhage and reduce any excessive bleeding. Any kind of condition that's going to overstretch the uterus during the pregnancy is going to make it more difficult for the uterus to contract after the birth. Women who have had more than 5 babies, that's somebody who's, a multiparous patient, is going to be at increased risk for postpartum hemorrhage because those muscle fibers have been stretched so many times that they may be flaccid after the delivery. Also, patients who experience a very fast or even a very long labor can have a uterus that's poorly contracted after the birth as well. Trauma to the cervix or the vaginal vault or the perineum can also cause excessive bleeding, and that can result from a fast birth or a large baby or operative vaginal delivery, which includes the forceps or the vacuum extractor. Patients who birth by cesarean section are at higher risk for hemorrhage for a couple of reasons. They've now had this surgical incision both through their skin and into the uterine muscle, and that can result in some bleeding. During the delivery itself, some of the endometrial lining is also removed by the surgeon, so that's going to add to that cumulative blood loss at the birth. It's generally going to result in less later postpartum bleeding for those women who birth by C-section, but during the birth, it's going to be a bit higher. Remember that the normal amount of time for the third stage of labor, remember the third stage of labor is after the birth of the baby until the expulsion of the placenta. That normal amount of time is 5 to 30 minutes. If it's taking longer than 30 minutes, the provider might suspect that the placenta, or if it's taking longer than 30 minutes, or if at any point the provider suspects that the placenta has only partially detached, they may need to go in and manually remove the placenta. If the patient does not have an epidural, they're going to provide some IV sedation first. Then the doctor or midwife is going to don a pair of sterile gloves and follow the umbilical cord through the vagina and locate the edge of the placenta. They're going to use their fingertips to separate the placenta from the uterine wall and then manually explore the uterus to just make sure that all of the placenta was fully removed. The placenta should be inspected thoroughly. That's after every birth. The placenta should always be inspected thoroughly to ensure that it's intact. Manual exploration may also be indicated if the provider suspects that there are any large retained clots, or if there might be some placental fragments that were retained. Any abnormal implantation of the placenta can also significantly increase the risk for postpartum hemorrhage. In the case of a placenta previa or a low-lying placenta, remember the site of attachment where the placenta is attached is really low in the uterus. And if you'll remember from our normal labor lecture, we talked about how the uterus contracts from the fundus, and the lower part of the uterus is typically pretty relaxed. So that part of the uterus, the lower part of the uterus, doesn't contract as well as the upper part where the placenta is normally attached. So there's going to be more risk for bleeding if the placenta was attached at that site. So you can appreciate how a low-lying or placenta previa can increase the risk for a postpartum hemorrhage as well. If the placenta were more deeply implanted, like in the case of an accreta, there's a risk that it's not going to fully separate, and any of those retained fragments can prevent the uterus from contracting well. It can't really clamp down on that site. Even if a placenta accreta does fully separate and all the placenta was removed intact, remember that the placenta is more deeply implanted, so there's more tissue that's involved there. That wound is going to be deeper, and that's going to lead to more bleeding. Some of the medications can also affect the uterus's ability to contract well postpartum. Oxytocin and prostaglandins that are used during labor can overstimulate the uterus, and ultimately that can lead to poor contraction postpartum. So that can, a constant sustained amount of oxytocin to induce or augment labor can really kind of backfire after the birth, whenever the uterus kind of is no longer able to respond to those hormones. A tocolytic, remember we give tocolytics sometimes, especially during a precipitous birth or precipitous labor. And if we give a tocolytic to slow things down a little bit, there can be some lingering effects of that drug, and that can cause the uterus to relax. And I don't want you to forget about magnesium sulfate. Remember, magnesium sulfate is given to prevent seizure for patients with preeclampsia. It's also given for preterm labor, but in the case of preterm labor, by the time once the birth is imminent, they would have stopped the magnesium sulfate. But particularly in patients who have preeclampsia, it's going to continue to be given throughout the birth and into the postpartum period. And remember, that medication has a relaxing effect on the uterus, and that can significantly contribute to uterine atony. And that's an important risk factor to consider for the patient that might be developing postpartum hemorrhage. Since cesarean birth does some cesarean births will require the use of general anesthesia. Typically, they're going to try and use spinal anesthesia for a cesarean birth, but it's not always possible. And whenever general anesthesia is used, it's going to cause that systemic muscular relaxation. So they're going to get the baby out as quickly as possible to prevent any so that the baby is fully perfused during the birth. But afterwards, the uterus is going to tend to be more relaxed, so that the care team really should be more vigilant, to monitor those patients after, that have had general anesthesia, and prepare for postpartum hemorrhage in the event that occurs. Maternal infection typically, it typically occurs after the birth of the baby, but it can occur during labor as well, in the event of chorioamnionitis actually infiltrating the inside of the uterus. And that infection can decrease the contractility of the uterus. If the infection exists in the postpartum uterus, that inflammatory process can lead to increased bleeding and then ultimately a postpartum hemorrhage. After the birth, there's going to be a clot at that placental site, and that's going to start to form right after the delivery. So any woman with a clotting disorder is going to be at increased risk for postpartum hemorrhage just because the bleeding is going to continue to persist. Uterine fibroids, those are also called lyomas. Those are benign growths that are on the uterine muscle, but because those growths are, present within the uterine musculature, it's going to cause it to not contract as well, and that contraction is necessary for effective to effectively stop the bleeding afterwards. So any presence of fibroids can also impair or increase the risk for postpartum hemorrhage. Some of the major signs of uterine atony they're listed here for you, but it's going to be a fundus that is difficult to locate, or maybe a fundus that's boggy. It's kind of a relaxed feeling of the muscle. So you may be able to locate the uterine muscle, but it feels kind of soft and relaxed. A uterus that becomes firm whenever it's massaged, but then starts to decrease after the massage is stopped. The fundus, if it's located above the expected level, remember that every time we document the location, the assessment of the fundus, we're going to be documenting where it was located. And if it's not in that same area, in that same vicinity, then that's going to, make us suspect potentially that there's, more fluid collecting inside the uterus. Excessive lochia, especially if it's bright red. So if there's lots of bleeding, and especially if it's bright red, that's an indicator that that's fresh blood. And then if excessive clots are being expelled, that's another indicator of a postpartum hemorrhage that's occurring. Remember that uterine atony is the most common cause of early postpartum hemorrhage. It occurs most frequently immediately after the birth. So as soon as the baby is out and the placenta is delivered, that's the most common time for the uterus to kind of, become atonic and relaxed. Remember that the uterus really needs to contract well so that those blood vessels, the blood vessels where the placenta were attached, they can be constricted and keep the bleeding under control. A well-contracted uterus, remember it's firm, it's about the size of a large grapefruit. It should be midline and at about the umbilical level. Bleeding should be scant to moderate in amount, and it should be dark red in color, not that bright red fresh blood, but kind of a darker red color. Uterine atony is a lack of muscle tone, so those blood vessels are not going to be well ligated. This relaxed whenever the muscles are relaxed, it's going to allow for rapid bleeding of those endometrial arteries at the placental site. Bleeding is going to continue until those muscle fibers and stop the flow of blood. So it's really important that we're, assessing the uterus frequently per our protocol in the postpartum period, and maintaining that nice firm uterus. Again, like I said, the atonic uterus is usually boggy and soft on palpation. It might be difficult to locate, especially if it's really relaxed. It can firm up with massage, but then relaxes again after the massage stops. Uterine atony is usually combined with excessive amounts of lochia and clots because that bleeding is just going to flow out. Our goals for management of uterine atony include getting the uterus to contract and treating any hypovolemia that might occur as a result of that excessive bleeding. You'll see here on this slide, there's two different images. There's a well-contracted uterus and one that has that's atonic. You can imagine the assessment of these two patients would vary from one to the other based on these images. In the first one, you can palpate the uterus nice and firm. In the second one, it would be more boggy. And again, ideally, we're going to try and prevent postpartum hemorrhage. So we're going to be assessing for and identifying risk factors throughout their prenatal care, from the get-go. And we also want to be monitoring this patient upon admission to the hospital and ongoing throughout their stay until they're discharged, and even beyond. We want to be, particularly for those patients that are at higher risk. We would give IV or IM Pitocin routinely after all births. So every time, as soon as the placenta is delivered, there's going to be a dose of oxytocin that's given to encourage the uterus to contract well. This is a prophylactic dose. Beyond that, we're going to follow the hospital protocol for low-risk patients. That's usually assessing the uterus and the bleeding every 15 minutes for the first hour, every 30 minutes for the next hour, and then hourly for 4 hours. And then it kind of the time span increases beyond that, because remember, it's so important to the first hour is going to kind of be the most critical, so we want to be monitoring it most frequently during that time. Moms with risk factors might need more frequent evaluations. Whenever we assess the uterus, we'll be assessing for the uterine size, the consistency, and the placement. All of those things should be documented each time, as well as the amount of bleeding. In the first, like I said, in the first 24 hours, the uterus should feel firm, about the size of the grapefruit, and about the level of the umbilicus. As we're assessing bleeding, remember lochia should be dark red and scant to moderate. Heavy bleeding is usually pretty obvious, and that's usually, considered a more scary event whenever there's heavy bleeding. But remember that slow and constant trickle of blood can be just as dangerous. We should also be monitoring vital signs, per our protocol as well. The nurse is going to be responsible for patient assessment and the initial management of uterine atony, because it's the nurse that's going to be, monitoring the uterus and identifying whenever atony is present. If the uterus is not firm upon assessment, remember the assessment, we're just checking to see if it's firm. If it's firm, we just check the bleeding and move on. But if it's not firm upon assessment, the nurse should provide some uterine massage until it does become firm. Clots might form in the uterus, and that might prevent effective contraction. So that might be one of the reasons why. A full bladder might also lift the uterus up, and often it will displace it to one side. So if the uterus doesn't firm up, or it doesn't, if it doesn't initially become firm, we want to empty the bladder. So let's talk about that again, just everything we've done so far to prevent and manage uterine atony, just so we can go over it again. As soon as the placenta is delivered, the nurse is going to administer that IV or IM oxytocin to promote that uterine contraction. And then the uterus is going to be assessed per hospital protocol for firmness and then again for bleeding. If the uterus is not well contracted, do some massage and then reassess. If it doesn't become firm, or if it becomes firm and then relaxes again, we should empty the bladder. Once the bladder is empty, then uterine massage should resume. We're going to massage the uterus again. And if it's still remaining boggy, then provider should be notified. In the meantime, there's some medications to promote contraction that should be given. We've already given Pitocin, so if that's not effective, we're going to move on to something else. We're not going to give more Pitocin. Your book is going to describe 3 medications that are routinely given for postpartum hemorrhage. Those are misoprostol, which is also called Cytotec, Methergine, and Hemabate. As you guys have been to clinical for obstetrics, you have completed a drug guide for each of those medications. I encourage you to review those nursing considerations related to each of those medications. We'll talk about them some more during our live session next week. I also want to make sure that you understand the process for assessing the uterus and how fundal massage is done. I hope you've had the opportunity to witness this or participate in the clinical setting. For those of you that have already been to the hospital or had some time on the unit, you've seen some fundal massage, and maybe you've had a chance to do it too. For both the assessment and the massage, you'll see that it's going to require both hands. One hand is going to be placed just above the pubic bone, as you can see there in the image. And that hand is going to provide some support for the uterus and also offer a little bit of counter pressure. The other hand is going to locate the uterine fundus. So you can see that the nurse is kind of assessing it between her hands, or between their hands, to assess the consistency and location of the uterus. The nurse who's assessing is going to if the uterus is not well contracted, the nurse can use their fundal hand, the hand that's on top, to provide some circular massage. Once the uterus is firmed up, the massage might help to express some clots that they formed in the uterine cavity. And remember, the job of that supporting hand during the massage is just to kind of provide some stability to the uterus and kind of guard it from any kind of prolapse that could occur. Following any fundal assessment or uterine massage, bleeding should also be assessed every single time. We should be looking at the amount of blood that's happening. I know this is a striking image, but it's important to include this one here. As I mentioned before, the nurse is going to call the provider. They identify uterine atony. Those medications are going to be given, but the provider should already be on their way. Once the provider arrives, the nurse should provide a report about the relevant risk factors, what's been done so far to manage this hemorrhage. The healthcare provider might manually explore the uterus, just like I mentioned earlier, just to go in and see if there's any retained clots or placental fragments. And then they might also perform what's called bimanual compression, which is what you see here on the screen. For bimanual compression, one hand is going to be inserted into the vagina, not into the uterus, just into the vaginal vault. The other hand is going to compress the uterus through the abdominal wall. This is really kind of mimicking the effect of uterine contraction. It's kind of forcing that contraction. In addition to this, there may be there's some other methods that we can use. There's something called a balloon tamponade, which is a balloon that's actually inflated into the uterus to provide some pressure on those uterine arteries. Packing may also be inserted into the uterus to apply pressure to that wall, and really just the goal is to stop the bleeding. Beyond that, if bleeding is going to continue to persist, they may take the patient back to the OR for a laparotomy. That's to open the abdomen and identify the source of the bleeding. There may be some sutures that are placed to ligate those arteries, and then at the end, if the bleeding can't be controlled, hysterectomy would be the last resort to control postpartum hemorrhage. I want to also talk about trauma. That can be play a role in postpartum hemorrhage as well. If we've got a uterus that's well contracted, but a patient it's still important to be checking that bleeding, because if bleeding is persistent, even though the uterus is contracted, the bleeding might be coming from some trauma. Trauma is the second most common cause of early postpartum hemorrhage. Following the birth, the healthcare provider, the doctor or the midwife, should be assessing the vagina, the perineum, and sometimes even the cervix, to see if there's any lacerations or trauma that is resulting in some bleeding. Risk factors for trauma include having a large baby, but again, remember, size is relative. It can depend on the patient as well. A precipitous labor or birth, induction or augmentation of labor, and operative vaginal birth. So using the forceps or the vacuum. Lacerations, that's like a tear that occurs in the tissue of the cervix, the vagina, or the perineum. Usually when the patient's pushing and there's the baby descends really quickly, that can cause some lacerations to that tissue because it hasn't had an opportunity to stretch. And like I said, the operative vaginal delivery, including the vacuum and the forceps, that increases the risk for trauma because there's more, there has to be more surface area to be exposed to help bring the baby down, but also the baby doesn't follow the natural curve as well as if the patient was pushing naturally. Episiotomy, that can where we actually do the incision into the perineal tissue, that can extend and that can cause a larger laceration, and larger laceration means more bleeding. Usually bleeding due to a laceration is going to be bright red, while normal lochia is that darker red color, remember. The amount of bleeding really is going to depend on the laceration. Management is going to include repair with sutures in most cases to control the bleeding. Hematoma is another form of trauma that might occur during a vaginal birth. The risk factors are the same for a laceration, but in this case, it's the deeper blood vessels that are damaged, but the overlying tissue is intact. So there's bleeding that's happening underneath the skin. Hematoma might be vaginal or vulvar. It could be retroperitoneal as well, so it could be really deep. It might cause a visual hematoma, like a bulging mass that's sensitive to touch, but it might also not be visible. It could be because it's deep in the vagina or in the retroperitoneal area. The nurse would suspect a hematoma if the patient's experiencing signs of blood loss, like signs of hypovolemia, like tachycardia, or decreasing blood pressure. The patient might also report deep and severe or unrelieved pain with pressure. The fundus will be firm, and the lochia is within normal limits because the bleeding is within the tissue. Most of the time, those small hematomas are going to resorb on their own. If it's a larger hematoma or a hematoma that's continuing to increase, it's going to usually require some intervention. Typically, they'll do an incision and evacuate the clots and then ligate any kind of bleeding vessels that are in there. Any nursing care for the patient with bleeding due to trauma includes recognizing that there's some uncontrolled bleeding, alerting the healthcare provider so that laceration can be repaired. It's important to remember that some lacerations can be really deep in the vaginal vault and difficult to see on inspection. So, what this case is going to look like is the patient who's got a well-contracted uterus, but the bleeding is just continuing to flow, and we can't tell where the blood is coming from, or sometimes you can see that there's blood flowing. You can see the laceration where the blood's coming from. Once the laceration has been repaired, the nurse is going to monitor for any signs of infection. Remember that REEDA acronym, REEDA, where we're assessing for the any signs of infection of that wound. We want to promote some comfort with an ice pack and teach that patient proper hygiene so that they're taking good care of that incision site and even monitoring for signs of infection themselves once they're going home from the hospital. Subinvolution is the most common cause of a late postpartum hemorrhage. Remember, late postpartum hemorrhage is one that occurs after 24 hours, but up to 12 weeks postpartum. Risk factors for a patient to develop subinvolution include attempting to deliver the placenta before it's fully separated, which might, include some retained placenta fragments. Manual removal of the placenta, both because that increases the risk for leaving some things behind, but also causing some, bringing some bacteria up and causing infection that way. Placenta accreta, remember there's some, it's a deeper growth into the uterine wall, and the risk for retained products. Previous C-section, uterine fibroids also increase the risk for subinvolution, as they increase the risk for retained placental fragments and poor contraction of the uterus. Early postpartum hemorrhage, so patients who experienced a hemorrhage within the first 24 hours, as well as advanced maternal age, are also risk factors for subinvolution. Remember that we would expect the uterus to decrease in size by about 1 centimeter per day, and after 2 weeks postpartum, it should no longer be abdominally palpable. So at the 2-week visit, if they come back to the clinic for a 2-week visit, we should no longer be able to palpate the uterus abdominally. Lochia should continue to decrease and follow that normal transition in the postpartum period. If it's starting to increase at any point, or if it regresses, like if it's starting to go from that darker red to that pinkish brown, and then to that lochia alba, where it's almost a whitish discharge color. If at any point it starts to regress back to that heavier, darker red bleeding, that's a sign of subinvolution, and that should be reported to their healthcare provider. Remember that retained placental fragments and infection are the most common reasons for subinvolution. That patient who's experiencing subinvolution is going to experience a slower recovery period. Bleeding is probably going to be heavier and persist longer than normal. It might also go back to a heavier, it might seem to improve, but then get worse again. If there were infection present, the lochia would have a foul smell. The uterus would feel larger than expected, and it might be tender on palpation. Because of the timing of a late postpartum hemorrhage, patients may have already been discharged to home whenever it occurs, because remember, they're going home after 2 or 3 days. So they may have gone home by the time a late postpartum hemorrhage occurs. So the nurse really needs to include a lot of teaching about assessing the uterus. The patient should be taught to palpate the uterus and understand the normal expectations of uterine involution. The patient should also know the normal color and the duration of their bleeding. So we often send patients home with, a form to document their pad counts or their bleeding, just so they can, we can, have a history of what their experience was like. And of course, the patient should notify their provider if there are any signs and symptoms. Medical management for subinvolution, the goal is going to be to control any excessive bleeding. Usually that's going to include some medications. Typically they go to Methergin to help, like a PO Methergin, to help to encourage the uterus to contract. Any retained products of conception should be expelled first. Usually some, medications are used for that. A sonogram might be ordered just to locate, to see if there's any retained products of conception. If there was anything, any large pieces left, they may require a D&C to be done to remove those placental fragments. And the patient may also need some antibiotics, particularly if there's infection present or if it required any invasive procedures to treat or manage the patient's symptoms. Okay, so hemorrhage is blood loss of greater than 1,000 milliliters. We know what the normal parameters are for a vaginal birth and a cesarean birth, but anything more than 1,000 milliliters, despite the method of birth, is going to be considered a postpartum hemorrhage. Most women can tolerate 1,500 to 2,000 milliliters of blood loss after a birth. That's because of the blood volume they've built up during the pregnancy. Remember, that's part of that. The process is they're going to create more blood so that they can, tolerate some blood loss after the birth. And as I mentioned before, the nurse should be weighing the pads and collecting any blood to be measured so they can approximate blood loss. And lab values may also be used to confirm or estimate blood loss if it's unknown. Hypovolemic shock is going to occur whenever there's excessive amount of blood loss. Remember, the most common sites of postpartum blood loss are going to be at the placental site. And then trauma along the birth canal is going to be a close second, maybe a distant second. Blood volume is going to decrease in the event of a hemorrhage. Blood volume is going to decrease. It's going to deprive vital organs of the oxygen that they need. The brain, the heart, and the kidneys are going to be the most vulnerable to hypoxia. Permanent damage can result in a short time, so it's important that we're, assessing and treating this really quickly. Once blood loss starts to occur, the body's going to attempt to compensate whenever, to compensate for the amount of blood that's being lost. It helps to ensure that oxygen moves to those vital organs, but it might mask the severity of the problem and delay the diagnosis and the treatment, especially if it's being masked well. Some of those compensatory mechanisms include the baroreceptors that cause the constriction of peripheral blood vessels. That's going to shunt the blood to the brain and the vital organs and away from the skin and the extremities. The skin may become cold and pale, and that really helps to ensure that the vital organs are getting enough oxygen. The adrenal glands are going to release some catecholamines that causes some vasoconstriction, so the heart rate and blood pressure are going to increase. Tachycardia is an early sign of compensation of excessive blood loss. If the blood loss persists or if it goes untreated, shock is going to worsen and those compensatory mechanisms are going to fail. Organ perfusion decreases and becomes inadequate, and then cellular oxygen is going to decrease. Lactic acid increases, causing metabolic acidosis. Metabolic acidosis is going to cause vasodilation, so that is going to cause bleeding to increase. At that point, there's not going to be enough blood to oxygenate the brain and the heart, and if treatment isn't imminent, then the patient's not going to be able to survive that amount of blood loss. So let's talk more about those physical manifestations of hypovolemia and what the nurse might find on assessment. Particularly because, like I said, sometimes blood loss can be concealed in the event of a hematoma, particularly a large hematoma. And if you have a hematoma where the patient's not experiencing that sensation because their epidural is so strong, it may be concealed for, it may be difficult to identify it. Sometimes symptoms of hypovolemic shock are going to be the first indicator that there's a problem. Again, because the patient's built up their blood supply during the pregnancy, they're capable of losing more blood than a non-pregnant patient before those symptoms develop. So keep that in mind as well. As I mentioned, tachycardia and hypotension are going to be the early signs, but they might not occur until 25 to 30% of blood volume has been lost, and that's a lot of blood. Blood pressure will initially increase but then decrease with a narrowing pulse pressure as the blood volume continues to go down. Respiratory rate is going to increase. That's because the patient becomes anxious with the loss of blood. They're going to try and take in more oxygen to overcome that hemoglobin deficit so they can get some oxygen to their body. Remember that vasoconstriction, that's going to cause cold, pale skin as there's increasing blood loss as that continues. There's some CNS changes. The patient might be anxious and then confused and then lethargic. Urine output is going to decrease and then eventually stop. That takes a little bit of time and may not be the most obvious sign, but urine output will decrease and then stop. Our goal is going to be to control bleeding and prevent permanent effects. So ideally, if we identify that a patient is experiencing hypovolemic shock, we want to call for a code and get help on the way. We may consider starting a secondary IV line with a large bore needle. A 14 to 18 gauge catheter is going to be required to deliver blood and fluid. Vasopressors can help to increase blood pressure, but ultimately our goal is to identify the source of bleeding and get it stopped, which kind of takes us back to some of those causes of bleeding. All right, I want to talk a little more about thromboembolic disorders, kind of moving on from hypovolemia and postpartum hemorrhage. This is the next kind of postpartum complication that can occur. Thromboembolic events are quite rare, but they can be serious. Approximately 1 per 1,000 pregnancies is complicated by some type of thromboembolic event. A thrombus is going to occur whenever there's a collection of red blood cells with platelets and fibrin within the blood vessels. That's some clot that's occurring there. Thrombi can form anywhere blood flows. So once that thrombi forms, it's going to impede blood flow. And then it's going to continue to enlarge due to the layering of platelets and fibrin and blood cells, because it kind of impedes the blood flow and then kind of continues to build. A large enough thrombus can block the blood vessel itself. That thrombus, once that blood clot forms, it can irritate and inflame the blood vessels, and that inflammation further occludes the blood supply at that spot. An embolus occurs whenever that blood clot is mobilized into the circulatory system. The blood vessels slowly branch off and narrow into capillaries, and that blood clot can get stuck, and it can fully occlude the blood supply. But why is this a problem? Why would it matter if it was in those those capillaries anywhere? Well, all the circulatory roads are going to eventually lead back to the lungs, and we have a clot that mobilizes and then gets lodged in the pulmonary artery. You've got yourself a pulmonary embolism. This is a potentially lethal complication unless it's recognized and treated very, very quickly. Embolism can also be caused by amniotic fluid can become swept into the circulatory system during birth. This is called antiphylactoid syndrome. We'll talk more about that here momentarily. But first, we'll get back to blood clots. The state of pregnancy itself is going to contribute to the development of thrombi. Remember that in a normal pregnancy, blood tends to pool in the legs because of the weight of the uterus. There's also increased blood in the legs and because of the hormones of pregnancy that causes some dilation of those blood vessels. If you have a patient who's immobilized for the birth because they've got an epidural, or it's been a long, or they have a C-section potentially, or if they have, they're in a particular position for a long period of time, that's going to increase their risk for developing a thrombi. Pregnant people also clot their blood more readily than non-pregnant people. Coagulation factors are going to increase during the pregnancy, and the fibrinolytic factors that cause the breakdown of clots decreases during pregnancy, and that all adds up to a hypercoagulable state. Clots form more readily, they break down more slowly. This is really useful whenever we've got a patient who's just released their placenta and their uterus is bleeding. It's nice that the blood will clot easily. That will decrease her risk for hemorrhage and keep her hemodynamically stable. However, it's this propensity for clotting is what causes that increased risk for developing a thrombus. So it's kind of a double-edged sword there. The third factor occurs more commonly during birth. Blood vessel injury can actually occur whenever there's trauma that causes some vascular damage. Think about your laboring patient who's had a really long or difficult birth, or where there's a lot of compression of those blood vessels, like whenever the baby is passing through the pelvis. Or also on the flip side of that fast and furious birth where the fetus passes through really quickly and causes some trauma to those blood vessels. Operative vaginal birth, like with the forceps or the vacuum, cesarean section, all of those things can also contribute to vascular damage, and that can lead to clotting. In addition, like I said, older women, those with varicose veins, obesity, a history of thrombophlebitis, and women who smoke are at increased risk. Box 28.2 in your book is going to outline some more of the specific factors that can contribute to thrombus formation. I really encourage you to read about those factors and think about the pathophysiology and how they might, contribute to the development of a thrombus. Whenever we're talking about thrombuses, there's really two types that I'd like to talk to you about. The first one, it's pictured here on your screen. You can see it there, and you may have seen patients with a thrombus like this before, but this is really what we're talking about. This is a superficial venous thrombosis. This occurs whenever when a thrombus forms in the superficial veins. These are near the skin, like near the superficial level. The skin over the vein is going to become red. The area is going to feel warm and is usually pretty tender. Because the blood that's within that vein is clotted, the vein often feels hard and cord-like, feels like a cord underneath the skin. It's not soft like a normal vein or like a varicose vein. The vein might feel hard along its entire length. Like I said, you can see that image there, and you can almost picture how that would feel if you were to palpate that vein there, because it's so obvious. These superficial venous thromboses are usually pretty self-limiting. There's usually not a lot that needs to be done about them because they're pretty self-limiting as well. The risk for these types of clots mobilizing and getting to back to the lungs is pretty low, but it can be painful for the patient. Some patients don't really bothered by them too much, but they can be unsightly and also quite painful. Management can include some analgesics and rest. Support hose are really useful. Elevating the legs will help to promote venous return. Warm packs can also help it as well. Anti-inflammatories may be used because remember, it's the inflammation that is really further occluding that vein. For the patient with a superficial venous thrombosis, they don't typically use anticoagulants. It's usually not that it's not that um, it's not, it's, what's the word? It's not an event that typically requires resorting to anticoagulant therapy. We want to teach patients to avoid long periods of standing, wear those support hose for prevention, particularly if she already has a history of superficial venous thrombosis or if she has some varicosities that are already present. Putting those support hose on early in the morning before she gets up and moves around really helps to prevent the formation or the worsening of a thrombi there. Complications are really unlikely because it remains in those superficial veins, as I mentioned. The deep vein thrombosis, that's going to be the one that's a little more complicated for a variety of reasons. The signs and symptoms are usually absent in the case of a deep vein thrombosis, but they might be attributed to normal the normal changes that occur during pregnancy. In this case, in the case of a vein thrombosis, it's going to be a much deeper. It's going to affect some of the deeper veins of the leg. There's going to be a clot that forms in those, the veins within the, deep in the leg. So it may not be as obvious to the patient or, on assessment. Symptoms are caused by inflammation from the obstruction of venous return. So if the patient is experiencing symptoms, they may have some pain in the leg or in the groin. There may be some swelling of the affected leg, some erythema, some heat and tenderness in that area. Homan sign, which is something that we've used previously in the past, is no longer considered to be a reliable or valid assessment tool. So we're no longer using Homan sign. If it's a severe DVT or a substantial DVT, it may actually cause the leg to be cool or pale because of that decreased peripheral perfusion. Those pulses may be affected as well. Like I said, the patient may have some tenderness and pain in that leg. It may be worse with ambulation, and they may feel some chills or stiffness, particularly in that affected leg. When diagnosis of a DVT is going to be by venous ultrasound, they may use some Doppler flow analysis. An MRI may be done, and then D-dimer tests may be also indicated for those patients. Prevention, like everything else, prevention is key. We want to try and prevent the formation of DVT so that we can effectively decrease the risk for pulmonary embolism for this patient. Any patient with a history of DVT or pulmonary embolism are going to be at increased risk. So those patients may require some prophylactic heparin. So if they've had a history that may be an indicator for prophylactic therapy, they'll use heparin during pregnancy. During the birth, we want to use padded stirrups to help to reduce any pressure and limit the time that the patient's in the stirrups, because that is, effectively some very specific pressure right on those legs. We want to get the patient up and ambulating as soon as possible after birth. That's ambulation after birth is a lot of things, but also good for the prevention of DVT. Compression socks before getting out of bed to prevent congestion of those veins. We want to teach patients how to put them on, because rolling and bunching can really make things much worse if those socks are not applied properly. For the patient who is in bed for a prolonged period of time, we want to be using our SCDs whenever the patient is in bed. We should be assessing the patient's legs at the same time so we can compare them. That's part of our initial and ongoing assessment while the patient is in the hospital. DVT is usually unilateral, and it's more often on the left side. We want to assess the legs for warmth and redness that would indicate inflammation. Any paleness or coolness would indicate that there's venous obstruction. We want to be checking those pedal pulses, because decreased perfusion to those, down to the bottom of the legs would indicate some obstruction there as well. We may be measuring leg circumference, particularly for patients that are at higher risk. We would ask patients about their pain. Pain would be oftentimes due to tissue hypoxia, and increasing pain, and usually indicative of more progressive obstruction. Prevention of any venous thrombosis includes a lot of things we've already been encouraging. We want to teach patients to increase their circulation with regular activity, particularly for patients who have jobs where they're in one position for prolonged periods of time. We want them to be active and mobile during their pregnancies, avoiding long periods of standing or sitting in one position. Elevating the legs whenever they're sitting. Avoid crossing the legs. That both of those things will help to prevent venous return. We want to make sure they're getting plenty of fluids. Adequate fluid intake prevents dehydration. Dehydration lends itself to sluggish circulation, so we want our patients well hydrated. Of course, we want to teach smoking cessation. Tobacco use is going to impair circulation, and that's definitely a risk factor for the formation of a thrombus. Pulmonary embolism is a very serious complication of DVT. The embolus, if a clot is formed, the embolus can occur whenever that clot is mobilized and it's moving through the circulation. If that embolus lodges in one of the blood vessels and impairs blood flow to the lungs, the blood is not going to be flowing to the lungs, and those lungs are going to be obstructed. If blood flow is completely occluded, death can occur in a matter of minutes. So it's important that we're vigilant about this. In the case of a very small embolus, circulation can be maintained and treatment can be initiated pretty quickly, and the patient can survive it. Signs and symptoms are obviously they're going to depend on the level of obstruction. Dyspnea, chest pain, tachycardia, tachypnea are most common. Also, decreased oxygen saturation if we have a patient on a pulse ox. Pulmonary embolism is typically diagnosed with a chest X-ray, pleural effusion, and ataxalus. A-T-E-L-E-C-T-A-S-I-S. I'm not going to say that one right today, folks. Sorry about that. Maybe one of you guys can help me bring that on our live session. I'll provide some levity for our little lecture today. But that's going to be present on the chest X-ray. If we're doing blood gases, there's going to be decreased partial pressure of oxygen. Patients who have a known DVT, if they already know that they have a DVT present, then they're going to have increased surveillance. We're going to be watching that respiratory rate and breath sounds. We're going to be keeping them on a pulse ox. Obviously, we want to report any abnormal respirations, any shortness of breath or tachycardia immediately. Our management for a patient who develops a pulmonary embolism, the goal is going to be to dissolve that clot and maintain circulation. We'll be putting the patient on oxygen via mask just to help to give them the most oxygen as possible. Narcotics can help to reduce pain and apprehension for that patient. We want to elevate the head of the bed to reduce that dyspnea. We want to continue to monitor vital signs, pulse ox, blood gases. Like I said, heparin is given for patients that are still pregnant, and that switches to warfarin after the birth. They can give warfarin after to the postpartum patient, but heparin only during pregnancy. Only heparin during pregnancy. The next complication that I want to discuss with you is peripheral infections. That's any type of postpartum infection. Postpartum infections can comprise a wide range of entities. They can occur after vaginal birth and C-section birth. They can occur during breastfeeding. In addition, if we've got a patient who's experienced some trauma during the birth, or because of the cesarean section, physiological changes during the pregnancy actually contribute to the development of postpartum infection. Some of the common sites for postpartum infection include the uterus, the bladder, the breast, and the incision site if the patient experienced a C-section. Likewise, lacerations that may have occurred can also contribute to postpartum infection. Most of these infections, that the patient may experience can be easily treated whenever they're identified early. So the key is prevention and early identification, so we can improve outcomes. Infections that aren't identified and treated early can lead to serious complications such as abscess formation, cellulitis, thrombophlebitis, and then septic shock ultimately. So it's ideal that we're assessing that and treating it quickly. Let's see. Overall, prevention, hand washing, proper hand washing and good hand hygiene, decreasing invasive procedures and utilizing sterile technique when indicated are going to help to prevent the onset of infections. In your textbook, there's a table 28.2 that's going to outline the risk factors for postpartum infections. I want you to review those and learn those because that's going to help you to to be able to correlate the risk factors with the type of infection, so we can help to prevent it. Many cases of postpartum infection are going to occur after the patient is discharged from the hospital. So again, teaching is so important. The postpartum period is mostly teaching. There's so much assessment that's done, but there's a lot of teaching that has to be done, both to the patient and to their partner or whoever's going to be helping them after the birth. We want to advise the patient to call for any signs of infection. Those are all listed here on your screen in the safety alert. You can read all of these different signs and symptoms of postpartum infection. The treatment for infection really depends on the type of infection. I do want to talk specifically about endometritis and mastitis as, those are more specific and more, specific to the postpartum period. We've learned about wound infections, prevention and treatment of those, and some of the other types of infections, but those are the ones that I really want to focus on today. Endometritis, it's also referred to as metritis. It's an infection of the endometrium, the myometrium, or the tissue where the placental site was, so the tissue where the placenta was once attached. And it can start in one area and then spread throughout the entire uterus. It's more common in women who have had a cesarean birth. In fact, around 2% of women who experience a vaginal birth, but up to 15% of women who have a cesarean birth are going to develop endometritis. So having a C-section is a significant risk factor. The uterine cavity, so inside the uterus, is usually sterile until the amniotic sac ruptures as a consequence of labor and delivery, and then any associated manipulations or bacteria that can contaminate the uterus that will expose the uterus to infection. Endometritis is an infection inside the uterus. It's characterized by postpartum fever, midline lower abdominal pain, and uterine tenderness. There's also some purulent lochia, chills, headache, malaise, and anorexia may be present. As I mentioned, cesarean birth is a primary risk factor. Prolonged rupture of membranes, prolonged labor, internal fetal monitoring, and intrauterine monitoring, like for monitoring the contractions from the inside. Meconium stained fluid, because meconium is a good growth medium for bacteria. Multiple cervical exams during labor and obesity are all contributing factors. Signs and symptoms of endometritis include elevated temperature more than 100.4. That may be present with or without chills. There's some midline lower abdominal pain and discomfort, uterine tenderness, tachycardia, subinvolution, remember the slowed involution of the uterus, malaise, headache, chills. Lochia is usually heavy because the uterus isn't well contracted. The lochia is often foul smelling whenever those anaerobic organisms are present. Foul smelling lochia is a later sign. It occurs when the entire endometrium is involved. So we don't want to wait or use that as our sole indicator of infection. As far as, for the patient with suspected endometritis, a CBC can assess for leukocytosis. Remember that white blood cell count is typically elevated during pregnancy, so that's not our only indicator. We may include endometrial or blood cultures to identify endometritis. A urinalysis can be done. Remember, we've got a patient who, those structures are close in proximity. So a urinary tract infection is not unheard of postpartum, and we want to be able to rule out urinary tract infection because the symptoms can be so similar. Management typically includes antibiotic therapy. It depends on the severity of the infection, though. If it was a mild case, it will, oral antibiotics and outpatient care will be provided for those patients. But for moderate to severe cases, those patients may need to be hospitalized. They'll continue those IV antibiotics until the patient has been afebrile for at least 24 hours. For the patient that is on any type of antibiotic therapy for endometritis, they should be starting to, have some marked improvement within 72 hours of those antibiotics. That should really get them to feeling better really quickly. Nursing care for endometritis, like all of the complications that we've talked about today, good nursing care includes reducing the risk. So we want to be educating the patient about proper hand washing techniques. That helps to reduce the spread of bacteria. Providing hand hygiene before the patient is doing peri-care and afterwards. We want the patient to, be using the spray bottle whenever they're voiding. That will help to, to clean the tissue well and, help to prevent infection. We want to teach the patient to wipe from front to back. We want the patient also to be changing her peri-pad at least every 3 to 4 hours or more. Or more frequently, because that lochia is a great medium for bacterial growth, and that can contribute to not only endometritis, but incision or laceration infection as well, like infection of that type of laceration. Again, early ambulation. Ambulation helps to reduce the risk of infection by promoting uterine drainage. So we want her upright and moving around. Fluids help to rehydrate the patient, so and adequate hydration reduces the risk for infection. So we want her to be pushing those fluids. Teach women to, maintain a good diet. We want a variety of sources of nutrients and good choices for food. We want her to have good protein and vitamin C. That both of those things aid in tissue healing, particularly after the birth. So whenever you're thinking about dietary recommendations after the birth, protein and vitamin C are going to be both useful for, aiding in tissue healing. We can continue to watch that white blood cell count. Remember, it's important to remember that the white count is going to be normally elevated after delivery for a little bit of time. So particularly if we're concerned about development of endometritis or other infections, we'll be watching that white blood cell count. Certainly for the patient who has developed an infection, we want to continue to monitor it as well. The neutrophils are going to increase, and we'll see a left shift in the white blood cell count whenever on the differential, whenever the patient is experiencing that type of infection. Again, monitoring for all those signs and symptoms and providing teaching about the signs and symptoms of endometritis. Of course, if there's any abnormal labs or findings, we want to report those to the physician or midwife for further evaluation as soon as possible. The nurse should be administering antibiotics as ordered and providing teaching about antibiotics for the patient, including continuing their full course of antibiotics until, despite how they're feeling, we want them to continue the full course. We want to talk about pain management measures for the patient who does have endometritis. It's important to get the whole team involved, so emotional and physical support from the family is also important. Because gravity is so helpful, we want patients who have had who experience an endometritis, an infection inside their uterus. It's so important for that discharge to completely drain that we want those patients sitting upright. Whenever they're not moving around, we want them, in a more upright position to promote that drainage. Let's see. Yeah, I think that's everything. Again, just making sure they're reporting any signs and symptoms, and you can go back to the signs and symptoms if you need to review that. The patient should be reporting anything that seems to be indicative of a postpartum infection. The next thing that I want to talk about is mastitis. Mastitis is an inflammation or infection of the breast tissue. It's most common among lactating women, although anybody, male or female, can experience mastitis whenever that tissue gets inflamed. Typically, for the breastfeeding patient, it's just going to occur in one breast. It's most often in the upper outer breast quadrant, but it can occur anywhere in the tissue. It usually occurs in the first 3 to 6 months of breastfeeding, but again, it can happen at any time. The most common bacterium that's reported in mastitis is Staph aureus. Usually it comes from breastfeeding because we've got the infant's mouth or throat where those bacteria can be present, and that can enter through cracks in the nipple, especially if there's trauma from breastfeeding. Patients who are experiencing mastitis will have very tender, usually engorged or erythematous breasts. So there's like a very tender, hard lump in that side where the infection is. Like I said, the infection usually occurs only on one breast, so it's usually unilateral. Mastitis itself, the infection of mastitis is generally self-limiting. We want the patient to continue breastfeeding, as breastfeeding can really help to clear the infection because the baby can empty the breast most effectively. The infection is not going to harm the baby. If there are antibiotics that are indicated, the infection generally resolves pretty quickly. Usually within 48 hours of starting that antibiotic therapy, the patient's feeling much, much better. Abscess formation can occur in up to 10% of women who develop mastitis. That would be a serious complication that would require incision and drainage. But our goal is to not get to that place. Mastitis typically starts with engorgement and the stasis of milk. So whenever a patient is skipping feedings, or if the baby's sleeping longer, or if they decide they're going to wean their baby, that can lead to the stasis of milk. Likewise, if the patient's wearing a tight constricting bra, that can impede the flow of milk. Any patient who has a suppressed immune system by poor diet or a lack of sleep, which is pretty common for new moms, that increases the risk for the development of mastitis. Let's see. Signs and symptoms of mastitis include flu-like symptoms, fatigue, muscle aches, fever, chills, headache. There can be a localized lump with pain and redness and heat, inflammation. There may be an enlarged lymph node, palpable, hard, tender area. You can see in the images here, what the patient might experience with mastitis. This is an earlier sign of mastitis on the left-hand side, where it's a smaller lump with tender axillary nodes. On the right-hand side, this is a more acute case of mastitis, where the lump has enlarged and those lymph nodes have become larger and more swollen as well, and more tender as well. Let's see. For the patient that does, like I said, with about 10% of patients with mastitis will go on to develop an abscess. That does need to be surgically drained in most cases. Most patients who are diagnosed with mastitis are going to receive some oral antibiotics, and like I said, that's going to help to improve those symptoms, usually within 48 hours. Again, risk reduction is such a key for improving reducing the risk for mastitis. Mastitis is less likely to occur if the breast completely empty, and if there's good breastfeeding techniques. Postpartum nurse needs to be teaching breastfeeding to their patients. Proper latch and a proper latch for the baby is so important. If we've got a baby who's poorly latched, that's going to lead to trauma to the nipples, which is provides an access point for that bacteria. We also need to be stressing that regular breastfeeding and breastfeeding on demand every 2 to 3 hours, and allowing the breast to completely empty with each feeding is going to be also critical for promoting the flow of milk and the prevention of milk stasis. We want to encourage breastfeeding patients not to miss any feedings because that can allow the breast to become engorged. Let's see. If the patient does develop mastitis, we'll teach them to apply cold or warm compresses to ease their discomfort. They can take an analgesic as needed. Again, it usually resolves pretty quickly with treatment, and the patient should continue to breastfeed or pump if they don't feel comfortable directly breastfeeding. We want them to pump the milk. The goal is to get the breasts completely empty. This is not a good time to wean their baby if a mastitis has started. We want to explain the importance of washing their hands before feeding. That will help to decrease the spread of bacteria. Also, proper hand washing for hospital personnel whenever they're providing care for patients and their babies. We want their hands to be clean. We want to teach breastfeeding patients about methods to decrease nipple irritation and tissue breakdown, making sure we've got a good latch, and that if we're removing the baby from the breast, that we're using a good technique. Like, we don't want to just be pulling the baby off the breast. We would insert a little finger, if we insert a finger into the baby's mouth to break the seal, that will help to reduce the trauma to the nipple. We want to encourage the patient to try other breastfeeding positions. Air drying her nipples after feedings is also helpful. Good diet, good fluid, plenty of fluids. Those things are key to reducing infection. Remember that breast changes are going to occur in the postpartum period. The bra that fit during pregnancy may not be the bra that fits in the postpartum period. So, and remember, tight constricting bras can contribute to the development of mastitis. We want their bra to be supportive and well-fitting, but not too tight. We can encourage the patient to massage the breast during breastfeeding, especially over tender areas and under the armpit. That's a common area for engorgement that will help to prevent the onset of mastitis. If the patient notices any lumps or swellings that are starting to develop, they should provide some additional massage in that area and promote the drainage of that area. So because lumps or clogged ducts can occur and contribute to milk stasis, and we want those lumps to come out with every feeding. Let's see. And to encourage the letdown of milk with breastfeeding, particularly for the patient who has mastitis, we would encourage some warm compress right before they feed the baby. That will help to promote blood flow to the area. The patient may initiate breastfeeding on the unaffected side. So because it's usually just on one side, we want to start breastfeeding on the opposite side at first. They can start feeding their baby there until the milk flow starts to let down, and then switch to the affected side. Because first of all, whenever you put the baby on the breast, they're typically really hungry, and they might be, more aggressive at the breast, and that can, be painful for the patient. So if we let the baby get a little bit of milk on the unaffected side, get the milk flowing, and then move the baby over to the affected side, that can really promote drainage there. That warm compress, like I said, it promotes comfort and circulation. We want the patient to continue breastfeeding, massage the breast, and promote that continuation of milk flow. Mastitis is relatively common, but we want to identify it and treat it early. If the patient receives antibiotics, again, teaching the patient about continuing those antibiotics until the full course is completed. And I think that's about everything for mastitis. A lot of information. Let's see. The last thing that I want to talk about are postpartum mood disorders. This is kind of a big one, and it's a heavy topic. There's a lot of information here. We've already talked about the baby blues that can happen. The psychological state of the postpartum patient is affected by hormonal changes, lack of sleep, the stress of bringing a new baby into their life, into their family. Many women are going to experience postpartum blues. It's postpartum blues. You'll remember that's short term, very limited. There's no medical intervention that's required. And after about 2 weeks, they're feeling back to normal, or at least their new normal. And those symptoms are going to subside on their own independently. Some patients will experience major mood disorders, and that can have a profound effect on their ability to care for themselves and for their babies. Mood disorders during the first year after childbirth have a substantial effect on the mother and infant relationship. So it's critical that we're identifying and treating these depressive or these mood disorders quickly. Two of the major mood disorders that I want to talk to you about today are postpartum depression and postpartum psychosis. Both of these disorders are going to be require the management of mental health professionals, to resolve these situations for the patient. The primary role of the perinatal nurse is going to be assessing for early signs of potential mood disorders, and reporting those findings to the woman's healthcare provider so that further evaluation and treatment can occur. Assessing for postpartum mood disorders and anxiety disorders should be included in the postpartum assessment and ongoing assessment for this patient. Let's start with depression. Depression is going to be the most common mood disorder in the general population. It occurs twice as often for women as men, so it's already more frequent for women than men. The initial onset of depression is peaks during the reproductive years, so this is kind of prime time for the development of depression. Perinatal depression, that includes major and minor depressive episodes that occur during the pregnancy or within the first 12 months after the delivery. This is one of the most common medical complications during pregnancy and the postpartum period. It can affect 1 in 7 women, so that's profound. It's in nursing care for patients. It really hinges on early identification and treatment for these symptoms. Perinatal depression and other mood disorders like bipolar disorder, anxiety disorder, they can have devastating effects for the patient and the infant and the family. In fact, maternal suicide exceeds hemorrhage, hypertensive disorders as a cause for maternal mortality. That's profound. That it's significant. It's a big issue. And it's one of the things that we don't talk about as much as we should. Perinatal depression often goes unrecognized because those changes in sleep and appetite and libido, they can be attributed to normal pregnancy and postpartum changes. It's normal to chalk it up to, oh, that's what happens whenever you're pregnant or whenever you've just had a baby. In addition, sometimes clinicians might not recognize those symptoms because maybe the patient's reluctant to report changes in their mood. They come to the clinic and they're feeling happy to get out of the house and they don't want to report those symptoms. In fact, fewer than 20% of women who have experienced postpartum depression was diagnosed with postpartum depression reported their symptoms to their healthcare provider. So that's just such a small subset of patients who actually experience those symptoms that are actually reporting it. It's really important that clinicians and that the perinatal nurse is asking the pregnant or postpartum patient about her mood. Postpartum depression is, like I said, it's a mood disorder. It's characterized by severe depression that occurs within the first 12 months postpartum. So this is a little different than perinatal depression. This is specifically postpartum. Postpartum depression affects the patient, their partner, the children, including the new baby, and everybody within the family unit. Patients who receive proper treatment for postpartum depression are often going to recover, but they may grieve that lost time with their infants. So identification and treatment early is so key, so important. You might be confused about the difference between postpartum blues, those baby blues, and postpartum depression. One of the I guess the most important things to remember is that postpartum depression is disabling. the patient is going to be unable to safely care for herself or the baby. Postpartum depression is classified as a major depressive disorder when the patient has a depressed mood or a loss of interest in pleasure of daily activity. This is going to be sustained for at least 2 weeks. And in addition, there are going to be at least 4 of the following symptoms. So, and those additional symptoms include significant changes in weight, like a weight loss or weight gain, insomnia or hypersomnia, so extremes in sleeping, changes in psychomotor activity, decreased energy and fatigue, feelings of worthlessness and guilt, decreased ability to concentrate and inability to make decisions. Some risk factors for the development of postpartum depression include a history of depression before the pregnancy, depression or anxiety that occurred during the pregnancy, poor social support, poor quality of relationship with the partner, life and childcare stresses. You can appreciate how those things can contribute to depressive situations, complications of the pregnancy or the birth. Being single or low socioeconomic status also increases the risk. Some of the assessment findings for a patient who is experiencing postpartum depression include sleep and appetite disturbances, fatigue that's more than what we would expect for caring for a newborn, being despondent, uncontrolled crying, anxiety, fear, and panic, inability to concentrate, feelings of guilt and inadequacy, feelings of worthlessness, inability to care for herself or her baby. Sometimes that's apparent on assessment, like whenever you see the patient, they may look poorly cared for themselves. They may have decreased affectionate contact or responsiveness to their infant, so they're not responding to their baby in a way that seems healthy. They may have thoughts of harming the baby. They may have thoughts of suicide or attempts of suicide. Management includes psychotherapy, social support, and medications. Ultimately, the patient who has been diagnosed with postpartum depression needs to be seen by a medical professional, by a mental health provider, so that their needs can be met in a way that is consistent with their diagnosis. Screening of the patient, of all postpartum patients, and providing resources about postpartum mood disorders during the pregnancy and the postpartum period is so important. And I want to really include the partner on this. Sometimes the partner is going to be the first one to recognize symptoms even before the patient realizes it. So it's really important that that we're taking a team approach to this. Because the patient may not be able to recognize those symptoms in themselves. The nurse should be reviewing prenatal records for risk factors throughout the pregnancy. They should be monitoring interactions more closely, especially for women who are at risk for developing postpartum depression. Some anticipatory guidance, like teaching the patient and their partner warning signs of postpartum depression that they should report immediately. We want to be supportive and encouraging in interactions. We want to provide patients with information regarding postpartum support groups and other community resources. Those are so vital. Having a good support system is so helpful. We want to provide support from healthcare professionals that can mitigate the onset of postpartum mood disorders. I want to talk about postpartum psychosis too. This is a variant of bipolar disorder and can be a really serious type of postpartum mood disorder. Postpartum psychosis is relatively rare, but the symptoms and the outcomes are typically more severe. The onset of symptoms of postpartum psychosis is pretty rapid. It can occur as early as 2 to 3 days after childbirth. The patient is going to develop some frank psychosis, cognitive impairment, grossly disorganized behavior, and that's going to represent a complete change in their previous functioning. Hormonal shifts, obstetrical complications, sleep deprivation, increased environmental stress can all contribute to the onset of symptoms. So depending on, other extenuating factors that can really contribute to the timing and the onset of symptoms. Women who experience postpartum psychosis are going to require immediate hospitalization and evaluation. They're at risk for injuring themselves and injuring their infant and the other children in their charge. Rapid and accurate diagnosis of postpartum psychosis is really, really important to appropriate treatment to allow for quick and full recovery and prevention of future episodes. We want to reduce the risk for both the patient and her children and family. Risk factors for postpartum psychosis include a known bipolar disorder, known history of psychosis, personal family history of bipolar, or any other affective disorders. Some of the assessment findings that we might see for these patients include paranoia, grandiose or bizarre delusions. Those are typically associated with the baby. Mood swings, extreme agitation, depressed or elated moods, distraught feelings about the ability to enjoy their infant, confused thinking, strange beliefs, especially things like that the patient or the baby must die to fulfill some type of prophecy or, premonition or something. Disorganized behavior. That's also included in some of the assessment findings. These patients need to be hospitalized. They will be hospitalized in a psychiatric unit so that careful, observed care can be provided for these patients. They will require some psychiatric evaluation. Usually medications are part of the treatment plan. Usually an antidepressant and antipsychotic drugs are given. Psychotherapy is also often included. And these are, while symptoms can resolve quickly with treatment, it's important that we're, managing and monitoring those patients aggressively. I don't like that word aggressively, but cautiously. We need to be very cautious in the management for these patients. A1, which is the Women's Health Nursing Organization, recommends that healthcare facilities that care for childbearing women are going to provide some education to professional nurses about the signs and symptoms of postpartum depressive disorders, both postpartum depression and postpartum psychosis. All patients should be screened for mood disorders throughout within the pregnancy and during the postpartum period. Nurses should be aware of the treatment options for patients who experience postpartum depressive disorders so that treatment can begin as early as possible. And again, reviewing the prenatal record, providing education and early detection and treatment can really help to improve outcomes for major episodes. The last thing that I want to talk about are anxiety disorders. Anxiety disorders can also crop up during the postpartum period, particularly for patients who have experienced, risk factors include a history of anxiety disorders, including panic disorders, obsessive compulsive disorders, and postpartum, post-traumatic stress disorders. Signs and symptoms of panic disorders typically include tachycardia, shortness of breath, feeling anxious, feeling of dying, or that they're going crazy. Patients who experience postpartum obsessive compulsive disorder, those patients may have, all-consuming thoughts, not just of harming themselves or the baby, or you're not being but also being an inadequate parent. They may also have thoughts that, overly concerned about the baby's well-being, maybe checking on the baby excessively whenever they're sleeping, to a point where it's interfering with their ability to parent or care for themselves or their babies effectively. Postpartum or post-traumatic stress disorder, really, what I want you to glean from that is whenever the birth is perceived as a traumatic event, particularly if there were some trauma during the birth, or, if you think about the birth that happened really fast and it was really scary, or whenever a complication evolved during the pregnancy or the birth, even if things turned out okay, the patient can experience some post-traumatic stress. Again, for all of these symptoms or all of these anxiety disorders, early identification and treatment will help to improve patient outcomes. We need to be assessing patients for these complications with every visit and every phone call. Patients who are at increased risk need to be monitored more frequently. There are a few different assessment tools that can help to identify postpartum depression, postpartum mood and anxiety disorders. There are, some actual forms that patients can complete to identify that can help providers as well. The nurse should always be looking for subjective symptoms. Any of those subjective symptoms or even some objective symptoms that might indicate we've got a patient that's experiencing a postpartum mood or anxiety disorder, so we can really improve her access to care and treatment. A lot of these anxiety disorders are, can be treated with psychotherapy. For some of those, they're going to require some medications to improve outcomes for the patient and to manage those. With any of these, truly with any of the complications that we've discussed today, it's important that the healthcare provider is considering the effect of breastfeeding for the patient. Some of the medications that may be used for treatment, particularly in affective disorders, whenever we've got a patient with a postpartum depression, postpartum psychosis, or anxiety disorders, many of those drugs all of the drugs should be evaluated for the safety with breastfeeding. So, of course, we have to consider the risks and the benefits. It's always better for, we've got to keep our patient healthy to be, for the health and well-being of the baby. There are alternatives to feeding the baby, but there are not alternatives to parenting the baby. So we want to keep our patients safe by delivering the medications that they need, and then finding alternatives for breastfeeding if the medications won't allow it. Yeah, and that's it. I know that was a lot of information and delivered really, really quickly. Like, I talked faster in this lecture than I have in lectures past. As you're going through these things, these concepts, and as you're listening to these lectures again, I want you to really be thinking about risk factors and signs and symptoms, the nursing care and teaching, and how we can help to prevent some of these complications, and the nursing interventions that will help to mitigate worsening complications. As you're thinking about these complications as well, I want you to think about what might happen if we don't provide treatment. I think I've covered that with just about every one of these complications. What happens if we don't recognize the signs and symptoms, or we don't avail a patient of the treatment options available? Be thinking about all of those things. On Tuesday, whenever we meet, we'll be covering some of these all of these topics all over again. And if we can either use the learning guide as an outline for our discussion, or we can go over some concept mapping for each complication. I'm open to either option, but whatever works for you is going to work great for me. In the meantime, I hope you have a really lovely weekend, and I will see you all on Tuesday. Bye.